Well, good morning still, but welcome to our lunchtime keynote on recovery incentives for California's contingency management program. I am delighted to introduce these people who are my colleagues and also my dear longtime friends. I don't say old, I say long time. And we've worked together for just about 20 years. And our paths have gone like this through our careers, and they're back together, and I couldn't be more delighted about that. Dr. Tom Fries is the director of UCLA's Integrated Substance Abuse Programs. He's a clinical psychologist. He has been in the field for his entire career, really promoting compassionate care for people who use drugs. And just delighted to say hello and introduce you to him. And then also Beth Rutkowski. Yes, please. Applaud. Beth Rutkowski is an epidemiologist. She is the director of training at UCLA ISAP, and is behind many of the trainings that you have all attended, the curricula that you may use and benefit from, and again, of just a dear friend and colleague. And so you are all in for a treat to learn more about California's efforts to implement contingency management. And I'm going to turn it over to them without further ado.
Thanks, Gloria. Thank you very much, Gloria. Good morning, everyone. Thank you very much. We hope to make this somewhat interactive. We do have a lot of information to share with you, but we want to make sure that we leave time at the end to have some open discussion. How many people have heard about the coming California Contingency Management Program? Raise your hand if you have. Well, what's really exciting is we are launching in California for the first time in this particular way, an evidence-based practice, and we're not going small. This initial pilot will involve over 100 sites across the state, both rural, kind of medium-sized, and urban areas, and will provide a new opportunity for us both to look at ways of rolling out evidence-based practices, but more importantly, to save the lives of Californians who are dying today from stimulant use disorder. So you're going to hear along the way, thank you very much, you're going to hear along the way that there's been some delays in this project. Originally, the timeline said that we were going to start services July 1. We'll talk about what those delays are, but we're pushing really hard to get these services implemented as quickly as possible, because every day that we wait, someone else dies who could have been saved by these services. So recovery incentives, the contingency management program here in California, is not without controversy. And so I want to make sure that we talk about what it is and what it isn't, and that we have plenty of time to talk about what your concerns are about its implementation. Beth is going to say this again, so she'll remind you. We are doing the overview training that's required if you're participating in the contingency management program. If your agency is participating, it is required, but it's open to everyone because we want everyone to know about contingency management. We're doing a live version of that following these plenary sessions, so you're welcome to attend if you'd like. Talk about the program. The unique thing about the California Recovery Incentives Program is the way that it's funded. And what we're allowed to do and what we're some additional freedoms that we have within the context of the program based on the way that it's funded. Oh, neither Beth or I have any conflicts of interest or anything to disclose. A reminder that it's National Recovery Month, and I think this fits right in the center of things. Recovery is individualized, and how each person gets there and what they define as their own recovery is their journey. And this provides us another opportunity to step into that journey with them and provide them a service that can help them along the way. So what are we talking about? The Recovery Incentives Program. In discussing the launch of this program, we really didn't like the cold, sterile language of contingency management. It's a research term, but what the hell does it mean, right? And so in talking about what to call it and in trying to find a name that would speak better to the people who can utilize these services, we came up with this concept of recovery incentives. Elsewhere in the country, they're calling it motivational incentives, which I think is also nice. But then you talk about MI motivational incentives and MI motivational interviewing, and everyone's confused in every conversation. So we're going to call it recovery incentives throughout the course of this program. Why? Well, California's had a major stimulant use disorder problem within the state for more than 30 years. We've kind of led the country in an ongoing basis. It swept across the country from here, it swept back across the country to here, but it has never left here. More Californians are admitted into the treatment program for stimulant-related problems than any other substance in 2020 and in the first quarter of 2021. And so you take all other substances, stimulants are number one in California, unfortunately. We have medicines for opioid use disorder. We have medicines for alcohol. But in spite of trying over 40 compounds to date that should have worked to be a treatment for stimulant use disorder, we haven't had anything that's worked well enough that it's gained FDA approval at this particular point. So we have no medicines that we can use regularly for the treatment of this particular disorder. And across the country, stimulant use disorder is increasing. More and more people are dying. And if you look at the overdose death rates, which we'll see in a minute, those rates are continuing to increase. And so we're seeing what was already a crisis continue to be more of a crisis. And it works. There are lots of studies, and we'll talk about those as we go along, but that demonstrate that when compared to all other behavioral interventions, contingency management works the best in terms of helping people stop stimulant use. Now, it doesn't repair their lives. It doesn't do all the other things that we need to do along with recovery. So we want to connect people with really good services. But people who are currently still doing okay may opt just for contingency management. And what we found is those effects last for up to a year. That's as long as we follow them. So we don't know how much after that. Those effects last for up to a year after they stop receiving the services. So it's a good program. It works better than anything else for this particular disorder. And if we connect them with all the other supports they need, we should see similar results to what we've seen in the research trials. It's been studied a lot, first and foremost in the VA. There's been lots of look at kind of how to manage it and how to do it in the best way possible. The program that we're running here in California is the first time the Department of Medicaid and Medicare Services has approved this particular service as a benefit under Medicaid. And so they're looking at California with an amazing amount of scrutiny to see, one, does this work? And two, can we use these incentives without even the whiff of fraud happening? Right? And so you're going to see that there are lots of rules in terms of how we implement this, because we have to do it right the first time, because we only get one chance. And then we can look at adapting from that point more and more as we go along. So we're going to implement a very specific set of procedures that will require specific knowledge and skills in order to implement according to the protocol that has been set forth. Yeah, and we're going to ask you to do exactly that. You'll hear a lot of contingency management training where they say, and you could choose this or this, and you could do it this way or this way or this way, and you can offer this kind of incentive or that kind of incentive. While that may be true, we're not going to get good results out of that because there's so much variability. We don't know what that means. So for this first go round, we're going to do one thing. We're going to all do it the same way. And we're going to do it really, really well. So then we can figure out how to adapt it to specific populations or specific settings. One of the keys to success, we believe, is to make sure that the person who's delivering the contingency management intervention is an individual who's expertly trained for that intervention. Not every counselor in the shop, right? It's an all positive intervention. It requires a specific set of skills. And so we're going to ask each agency that's participating to identify someone who will be their CM coordinator, and they will be the primary deliverer of these services. They'll be specifically trained, and only those people or their backup or their supervisor for this particular service will be able to deliver this particular intervention. Then they'll go out into the rest of the agency and they'll receive all of the other services that they're entitled to within the context of that agency. We need a lot of buy-in from the agency because the agency staff could badmouth this intervention. Remember buprenorphine back in the day, right? You had some staff who were like, yay, let's go. And other staff were like, you should get off that shit as quickly as possible. And for those agencies who had that staff, it was much harder to get people stabilized on buprenorphine. And we saw that in the data. So we want everyone in your agency to be on board and cheerleaders for this service, even if they're not directly delivering the service. So we will make the overview training and other trainings available to everyone so that we can have a good common set of knowledge. How does this work? First of all, people who come into your program will need to become clients of your program. So they'll be identified through the intake process as having a stimulant use disorder in need of care. If they choose to, they can participate in a 24-week recovery incentives program. The first 12 weeks are exactly as it was done in most of the research studies. Twice a week coming to clinic, twice a week providing urine drug tests, twice a week opportunities to receive incentives. The second 12 weeks is really about engagement in ongoing care. We know that retention in services is one of the only predictors we have of how well someone's going to do in the long term. And so the second 12 weeks will have a standard set of incentives, lower rate, only once a week, but designed to keep them coming in, keep them engaged with your service system in order to keep them receiving the services that they need. Currently, over the course of the 24 weeks, they can earn a maximum of $599 in incentives, about $480 in the first 12 weeks, and the remaining in the second 12 weeks. That $599 tax is really, cap is really a tax-related issue. If someone earns over $600, the person paying them would need to give them a 1099 form for the IRS. That creates all kinds of logistic issues. DHCS is looking at that issue right now and may determine that this is a health benefit, not income, and therefore this cap doesn't apply, and or that there are easier and more efficient ways of handling those tax issues should they come up. So the one thing that we don't know right now is, will we implement with a $599 cap? Or will we go closer to what the research literature said, which is significantly higher than that? And I won't disclose those amounts now because I don't want to get anyone's hopes up or dash anyone's hopes by giving those numbers. So what will they do? They'll come in, they'll give a urine drug test. It needs to be a point of care on-site urine drug test in order to work for a recovery incentives program. The provider will read that test, and if it's negative, they'll get reinforcers for that particular day. We are testing only for stimulants for the purposes of the recovery incentives program. We will also test for opioids as a safety measure to see if they need additional care, maybe referral to medicines for that particular disorder. And we want to give them some good education regardless about fentanyl because of the cross-contamination of those substances. But in terms of the recovery incentive, it'll be based only on stimulants. That is research-based as well. If we try to tackle too many problems at once, we find we get no results. But if we tackle one problem at a time, we find that those results often sort of spread to other troubled areas within their lives as well. And so they tend to do better overall in terms of their own ratings of the quality of their life and the kinds of issues that they're serving. So we're going to follow that research, and we're going to look only at stimulants for this purpose. We're also going to take the management of the actual incentives out of everyone's hands. They won't be in my hands, they won't be in your hands. They're going to be in the hands of a program called an incentive manager. The incentive manager, the request for applications for the incentive manager is out now. People are applying to provide this particular service. So we don't know exactly what it'll look like until the contract is awarded. But basically what it'll do, it'll be a software program. You go in, you put the results of your urine drug test into the incentive manager. It calculates the incentive, which is actually quite complicated in terms of how it's delivered. And it tells you what incentive should be delivered on that day. And then you'll deliver the incentive however the incentive manager delivers them. All of that will be covered in the implementation training when we get there, because we won't start that until the incentive manager is in place so that we can walk you through that process. In order to participate in the Recovery Incentives Program, there are a few stipulations. Because it's a Medicaid benefit, you have to be participating in the DMC, you have to be a participant in the DMC-ODS county, and you have to be providing DMC-ODS related services. So there are, I think, 35 DMC-ODS counties. 24 of them applied to participate in this particular program, and the 24 are listed here. Each county selects their own sites that will participate. Some of them selected 2 or 3 sites. Some of them selected 30 or 40 sites, mostly depending on the size of the county. I will say right now, there are no tribal sites in the list of participating sites at this point, and I think that's a travesty because it's one of the most impacted communities. So I would encourage you, if you're in a DMC-ODS county and it's one of the counties listed here, and you happen to do tribal work directly or indirectly, to work with your counties to identify sites that could participate. We are still allowing counties to add sites now. I don't know how long that will go on. Certainly to the end of the year, I'm guessing sometime into early next year before we close the cohort and run the pilot as it is. So if you're interested and you're not part of that, you should talk to your county representatives who can determine whether or not it's appropriate for you to participate through their county services. UCLA was awarded the contract, and that's why I'm talking about it today along with Beth, to provide the core implementation training and implementation support services. So we're working with DHCS to understand the protocol. The overview training that we're doing later this afternoon is the first step in that training. For the participants, we'll also do some additional, more intensive training to help you learn the procedures that are necessary. This is our training team. Where are you? Oh, there you are. Beth and I are running the training team along with 2 trainers, a couple of project directors, and some administrative support along the way. We're here to help you. So if you're participating in the program and there's anything that you need in terms of technical assistance in order to be successful, we can't be successful if you're not successful. So please tell us what's not working or what you're struggling with so that we can help you gain those skills and troubleshoot any problems that you're having. DHCS, of course, is involved. Tyler Sadwith, the Deputy Director of Behavioral Health, and Anton Goose-Bland, who's a clinical consultant, but is actually the person overseeing this program for DHCS. And we're also working with our colleagues at Washington State University, Mike McDonald, Sarah Parent, who actually have done more training on a smaller version of contingency management than anyone else in the country. So we started with their materials. We're adapting it for the California protocol with their permission and their consultation, and taking the best of what we already know and expanding it. And Sarah Becker, formerly from Brown University and the director of the New England ATTC, is an implementation researcher. So we're looking at how to implement evidence-based practices in real time using her expertise and her knowledge. So the timeline is a little loosey-goosey right now, but this is kind of how it lays out. The original applications were in February to April of 2022. The 24 counties that I showed you earlier were selected to participate. During this intervening period, they're expected to hire or identify their CM coordinator and make sure the billing codes that, fortunately, Beth, because I don't get billing at all, will go over with you in just a couple of minutes into your systems and prepare yourselves in order to implement the protocol. Every staff person that's participating, the CM coordinator, the CM backup coordinator, and the CM supervisor will be required to complete the CM training, the CM overview training, and then participate in a 6-hour virtual nuts and bolts or implementation training. That'll be divided into 2 parts, so it'll be 2 3-hour sessions that everyone will need to participate in. We'll schedule a whole bunch of those, and it's really nice if your whole staff can come at the same time, but we recognize that agencies still need to run. And so you may need 1 or 2 staff to go here and 1 or 2 staff to go there. It's great. Everyone just needs to do the training. It'll be the same training each time that it happens. After that training, are you covering the readiness assessment? You are. Okay. After that training, there will be a readiness assessment. Do you have everything in place in order to be able to do this protocol according to the protocol? Beth will talk about the details of that in just a few minutes. Once you pass the readiness assessment, we will say you're ready to go. DHCS will list you as an official participant in the Recovery Incentives Program, and you can launch services at that point. We anticipate that you should be able to do all of that. You can do the overview training now, the nuts and bolts, and the readiness assessment. If you're ready to go, like ASAP, you could probably get that done in about a month to 6 weeks. And if there's something that you're struggling with, you'll obviously need to add time on to that in order to accommodate that. You'll deal with the recovery incentive software, however that happens, just before launching services. And again, I can't give you the details of that until that contract is awarded. We're not leaving you alone, though, for good or for bad. After you implement services, we're going to ask each of those staff people to participate in an at least monthly coaching session. It'll help us evaluate how closely we're sticking to protocol, but more importantly, it'll help us help you deal with sticky situations, troubles, problems. You know, it's really easy when someone comes in and says, oh, great, I tested negative, thank you for my incentives. But when they say your test is stupid, you're all fucked up, and I don't know what the hell's going on, and this is absolutely wrong, and they're screaming at you, it's really hard to keep it an all positive intervention. We want to help you with that and make sure we work together to deal with those sticky issues as we go along. I'm sorry I dropped an F-bomb before lunch.
No, it's not. It's during lunch.
Oh, it's during lunch. Never mind. We're good. We're also going to, twice within the first 6 months and once every 6 months after that, we're going to do a fidelity assessment with you. We're just going to make sure that nothing has drifted off protocol. It should be very low intensity, low staff involvement, low burden, but we do need to make sure that we're still operating together. So what makes a good CM coordinator? They got to be organized. This is a clinical intervention, but it doesn't take a clinician to implement it. What it takes is someone with great compassion and great ability to communicate and who is highly organized, because a lot of what we're doing is tracking urine drug testing results and putting them into the system appropriately. So they need to be able to do those laboratory procedures, have enough computer skills that they can do that, and excellent communication skills. And they need to understand the privacy laws and all that other kind of stuff that's required in these kinds of services. They'll be responsible for implementing the entirety of the intervention, basically, collecting the urine, testing the results, entering the test into the system, ensuring delivery of the system in the appropriate way according to the incentive manager, and where necessary, communicating with additional clinical staff in order to get the person the services that they need. They test positive for opioids, for instance, and they say they'd like some services around those issues. We can connect them with the appropriate services along that way. Now, it's important to remember that this is a single intervention, that someone can come into your treatment program and say, I only want the recovery incentives program. I don't want any of your counseling. I don't want anything else. What are we going to say to that? Great, welcome, right? And we're going to watch them, and we're going to evaluate them, and we're going to have conversations with them. We're going to offer them support if they seem to need it. And they can say, yes, I want your support, or no, I'm good. I just want to keep doing the recovery incentive program. And so we're going to welcome them into this piece of the program and provide these pieces of the program as they choose to take advantage of it. Did I cover all of that? I covered all of that. Additional team members. Everyone in your agency will be a member of the CM team. It's really important that all the counselors, care managers, recovery providers, harm reduction providers, medical providers, everyone who's working within the context of your services should be available to deliver all of those services to these individuals participating in this program as they see fit and as they choose to take advantage of them. There will also be a backup coordinator, as we talked about, because people get sick, people take time off, people leave the agency and there's turnover. And to make sure we're doubly covered, the CM supervisor, who will also be trained along the way, will be able to provide those backup supports as well. It is likely that a county auditor will be involved in these processes as well, because there's billing involved and all of those sorts of stuff. And eventually, we want this to become a funded Medi-Cal service. And so ultimately, the counties will be implementing this themselves, and therefore need to be able to track and audit the systems as they were. So what we're going to do is we're going to teach them both the readiness assessment and the fidelity assessments as they're developed and implemented for this particular program, so they can add that to the other billing and other auditing that they do along the way as it becomes an ongoing sustainable service. I got a couple more, right?
Yeah, you go through that.
Okay, through the incentive schedule. Okay, I don't want to step on Beth's toes. So the overview training, again, we're going to do it this afternoon, but primarily it is an all virtual self-paced training. Beth and I and a few of our colleagues went through a set of PowerPoints and narrated them so that it's a set of videos that you watch. There are 7 distinct videos plus a little introduction that walks you through an overview of CM. It is not specific to the Recovery Incentives Program, but meant to give the basic principles of contingency management, so that when you come to the implementation training, we don't have to cover basic definitions and those basic concepts along the way. So these are the concepts that it covers. You can take that on entirely a self-paced basis, except for today, which it's 2 hours, that's what it is. But if you take it online, you can take it as you can, a 15-minute module, a 10-minute module, a 5-minute module, as you have time to do it until you complete all 7 modules. There is a knowledge check at the end to make sure you learn something, and you will be required to document the date that you attended that training when you register for the implementation training. Because while it's open to everyone, it is required to attend that training. The link is on our website on these slides. The link to the website is on these slides, and you will get access to these slides on an ongoing basis. And we are providing continuing education for both medical and behavioral health personnel for this particular training. After that, only those 24 counties and the associated sites who are participating in the Recovery Incentives Program will be invited to register for the implementation training. We are starting with only those sites because there's a minimum of 3, and if you have a number of sites, maybe 4 or 5 or 6 staff at each of the agencies. And to date, before we add any more, we have over 100 agencies that have been identified across the state that will be participating. So if you do the math, we have somewhere over 300 people that we need to train as quickly as possible in order to get these services rolling across California as soon as we can. As soon as you're ready, we want to make sure that you have the ability to get trained and launch services. So we're going to keep the trainings closed until we get that first cohort done. Then, because of staff turnover, because of additional interest, and because we want this to be a sustainable service, we'll open that training up to everybody or to more people, so that we can disseminate that knowledge more broadly after that. In the nuts and bolts training, we'll really look at the details of the protocol. What are all the tasks you need to do? There are 4 approved urine drug tests. You'll be using one of those. We want to make sure you know how to use the device that your agency has selected, for instance. How do you manage client flow through the agency, et cetera, et cetera. As importantly in that, we're really going to spend a lot of time talking about those clinical issues and doing some role playing and skill building around how to deal with different kinds of clinical presentations as they come up in the context of delivering these particular services. It really is essential that it be an all positive intervention. Again, it'll be 2 parts, 3 2-hour sessions, and continuing education will be involved, will be available for those as well. The incentives themselves. I told you that it was complicated, and you'll learn all about it in the implementation training if you're there. But what has been shown from the research is that the best way to implement these incentives is to make them increase in value for longer times of meeting the target behavior. So the longer you go with urine drug tests that are stimulant negative, the more you can make. So in this particular program, at these rates, if they don't change, we start with $10 for the first negative test. The next, after every 2 negative tests, you increase by $1.50. So it's $10, then $11.50 for 2 tests, and then $13 for 2 tests, then $14 for 2 tests. That continues to escalate as long as they're negative. The other key is reset. They have a positive test or they don't show. They get no incentive that day, so they drop to 0. The next time they provide a negative urine sample, they go back to $10. But when they get 2 in a row, they get all of the gains that they've made back plus the next gain, right? So if they're at $15 when they have a no-show, for instance, they drop to 0, get $10 for the first negative. The next negative, it's $15, and the one after that, it's $16.50. Right? So they don't lose everything. It's just a momentary blip in time to acknowledge that something different happened, and then we go right back to where we were before. That is really a critical component of this particular protocol. That's why it's complicated to figure out how much they're supposed to get on any given day. If someone were to test negative, every single sample, by the way, that doesn't happen. It happens about, the average person in the course of the research earned about 50% of the total incentives that were available to them across the course of the time that they were there. But if someone is able to maintain 100% negative urine drug tests throughout that process, this is how it would go. So it would go 20 to 23 to 26 per week, escalating up to week 12, where they would earn 2 samples at $26.50, $53 in total for that week, totaling $438. And then you see in weeks 13 through 24, it starts at $15 per sample each week, drops to $10 for a few weeks. And then if you make it all the way to week 24, you get $21 for coming in that week. Again, this is really just about continuing their engagement in the program in an ongoing way. I'm going to turn it over to Beth, and she's going to walk through a few more elements of implementation of the program, and then we will open it up for questions.
Thanks, Tom. Hi, everyone. Good job.
Thank you.
So before I continue, I want to do a couple of shout outs. And so a few slides ago, Tom showed you our team, our recovery incentives team at UCLA. This project is huge, as you can see already, and it afforded us the opportunity to grow our team, because the team members who you all have been interacting with over the past couple of years, Gloria and Brandy and Christian and others who you've interacted with at UCLA, are busy managing other projects. And so we needed to grow our team. And so in the room right now, we have one of our training coordinators, Julian Simmons. Raise your hand. So Julian joined our team just a few months ago. He'll be one of our 2 training coordinators. And then we have a team who's helping us down in LA to manage the logistics for the remote learners. So we've got Adrian Detrice, who's one of our 2 project directors, Sam Santamaria and Rosanna Trevino Perez are our 2 clinical trainers. You can't see them because we can't see our remote learners, but they're hopefully listening in, and they're part of the team as well. And then we have 1 more project director starting in October. And so we'll be fully staffed up in just a few weeks.
Thank you very much for that, Beth, and completely demonstrating that Beth is much nicer than I am.
And a shout out to the remote learners who have been with us since yesterday. Coding. So coding and reimbursement. So Tom mentioned this already. Some of you may be fortunate enough to have this responsibility within your clinics. And so there are specific codes that will be used for billing purposes. Those codes will be inputted into the incentive manager. It'll allow DHCS to see that you're billing appropriately for the urine drug testing. It'll help the evaluation team figure out the percentage of positive tests versus negative tests. It'll help our team with implementation support when it comes time for those fidelity assessments and coaching calls. So this looks like Greek to me. I don't do billing. So those of you who do the billing, these codes will probably look familiar and make sense to you. There's also some reimbursement guidance. So there's a range of rate that you can charge to be paid for the recovery incentive services within your clinic. So it ranges from $35.83 to $39.42 for every 15-minute unit of service. There is a chance counties could submit a plan for a different higher interim rate, and that sort of is happening between the counties and DHCS. But for the most part, there's a range in the reimbursement that you'll receive for the recovery incentives program.
And that range is designed to cover the clinical time associated with delivering the intervention, but also the urine drug test and other ancillary kinds of supplies that are associated with that. So it should end up being a budget neutral intervention in the context of your agency because you're able to bill for those services to cover those costs.
And there was also some startup costs that were distributed to the participating counties to allow you to hire your CM coordinator if you didn't have one already identified. So that is all sort of happening currently. So communication, because this is being done as a Medicaid benefit, there's some flexibility in how you can advertise the availability of the recovery incentive services to your potential participants. And there is going to be a communication toolkit that will go out to all of the participating sites to help you do that. What can I say? How can I advertise? How can I draw in new folks? And so this communication toolkit is currently under development. There are some FAQs on the DHCS website that talk a little bit about outreach and communication, but something more in depth will be forthcoming shortly.
Just one note about that. If you've been involved in the trust protocol or any other CM service before, there's issues about advertising how much someone, that you're paying, you can earn incentives within the context of those programs. Because it's a Medicaid benefit, we don't have that restriction. And there are restrictions against attaching an incentive-related visit to another Medi-Cal billed service within those contexts. That's not a problem in this program either. So they can come in, receive all the services that they need to receive, including this one, and everything is billable as it ordinarily would be without the concern that's generated by the OIG in that regard.
Thanks. Okay, so the readiness review. So Julian has a counterpart, a partner in crime. Her name is Lupe Cortez. She may also actually be helping us with the remote learners. Lupe is our other training coordinator who if you're one of the sites that's part of the program, you may already be hearing from Lupe just in building the site roster and communications around training. So Lupe will be responsible for helping our project director, whose name is Caitlin. She'll be joining us in October to do the readiness reviews. So it's a two-step process, essentially. Part one will be a Qualtrics online survey. Julian actually helped us to develop that in the past couple of months, where you'll go on and you'll answer a series of questions, just sort of self-report. There'll be things we'll ask you to upload, like your consent form and sample procedures and pictures of your clinic space to show us where you're going to do the urine drug testing and what the safeguards are for avoiding any tampering of the samples. And then once that part is done, we'll do an interview with you. So you'll be contacted to do an interview where we'll talk through the results of part one and just really make sure that you have everything in place to implement the protocol with fidelity. So once the readiness review is done, that's when you have the green light to get started. Tom already talked about the incentive manager. We're eagerly waiting for the announcement so that we can finish developing the implementation training. So much of the trainings is going to rely on who the incentive manager is and how it's going to work. And so we're looking forward to the decision as to who that will be. So urine drug testing, Tom mentioned that we're using point of care urine drug tests that can be administered and read right in your clinic without having to send it out for review. So we worked with an expert toxicologist who used to work for the National Institutes of Health. She was fabulous and very funny. So she helped us to come up with a short list of approved urine drug test products. That list will be forthcoming. We promise it. It's almost ready. But right now there's 4 products that have been approved for use in the Recovery Incentives Program. We're going to do training. Within the implementation training, we'll teach sites how to administer each of the tests. And we're also working with the California Department of Public Health to do a CLIA waiver, CLIA certification training. Apparently there's lots that needs to happen in order to be able to use point of care urine drug testing in your clinics. And so that will be happening, was supposed to happen last month. So it'll be happening soon. So you'll all have access to this short list of products. If you have a standard urine drug test that you use for other services that you want evaluated for approval, there's a process for how to do that. Essentially, you'll send us some information. We'll contact Marilyn. She'll review your product and she'll say yay or nay. Hopefully the answer will be yay. It may be nay.
What it'll be evaluated on is cutoff levels for what is considered a positive and a negative, and validity measures. So it has to contain 3 different validity measures within the context of the test in order to be considered for this particular purpose. So there will be a full list when the communication comes out of what you would need to provide in order to get your test evaluated.
Yeah, the validity measures are temperature, pH, and creatinine. Okay, so once you're launched and you're providing incentives to your participants, this is where Julian comes in. He's our coordinator for the fidelity monitoring and for the coaching and implementation support. And so we're going to do monthly coaching calls. It's going to be kind of like a learning collaborative where we bring folks together to learn from one another. What's working well? Where are you having trouble? Did you have a really difficult interaction with a participant and you need to talk through it to learn how to do it differently next time? And so our trainers and project directors and Tom and I will be organizing the monthly coaching calls. It'll be required one per month. We'll schedule them all across the day to make sure that there's one that's convenient for your CM team. But it's really our way to just keep in close contact with you all and provide support along the way. So we're not going to disappear once you start launching your service. We'll do training as needed. So if there is a recurring theme popping up across sites that warrants additional training, we'll do that for you. We're actually going to have a warm line. So it's our version of a TA request form where it's not going to be staffed, 24/7, but you'll be able to submit a question and you'll get a response within 24 hours. And so it sort of is our attempt to just provide you with as timely technical assistance as possible. As Tom mentioned, the fidelity monitoring is going to be twice in the first 6 months and then once every 6 months thereafter. Adrian and Julian will be primarily responsible for that fidelity monitoring process. And it'll be very similar to the fidelity for the readiness assessment where it'll probably be a 2-part thing. We'll have a survey and then we'll do a short interview. And it'll just allow us to identify areas where you need more support. Are you using the incentive manager properly? Are you submitting your billing codes as you should? Is the incentive escalating as it should be? All that.
I hate fidelity monitoring. I hate that phrase. That's what DHCS has been using, but I want to come up with a different word for it because it really isn't an adversarial process. We're coming in to check your fidelity. It really is a collaborative process where we're just looking for things that we can help with so we can all work together toward the same goal.
Yeah. We do have an evaluation team also based at UCLA. Darren Urata and Howard Padua are the leads for evaluation. Some of you may know those folks. The key message with evaluation is we want it to be as low burden as possible, right? You all have so much data collection responsibility. And so the vast majority of the evaluation efforts will be done using existing data. So data that's going to be inputted into the incentive manager, existing encounter data, the data that you submit to DHCS for general DMC-ODS services. They're going to be able to cull through that data and pull out what they need. Where they'll be interacting with staff at the sites is doing and also the participants, is doing provider and client surveys and interviews. Really to do a qualitative analysis to see, what's working well, where are there issues that need to be addressed. So that is not going to be it's not going to be a high burden activity. They're going to keep it as low burden as possible. So what's next? So some counties and sites have already started to hire their CM coordinators and get ready for the launch. But given the delays, we know that some folks have said, okay, we're going to sit tight and wait until things are a little more solidified. So we're sort of in this gray area of waiting for stuff to get moving again. Yeah. So that's the end of our formal presentation, and we have about 15 minutes before Soma gets to present. And so this is how you can reach us. So information. Oh, do we have it in here? No. So there is a CM website on the DHCS website, which we can make sure you all get access to. On that website, there's this master FAQ document that is quite a beast. It's like a culmination of 3 or 4 different FAQs. It will be a central email box for folks to send questions in about the Recovery Incentives Program. So that you'll be able to everything will be centralized through one email, and then they'll route the questions to the appropriate people. For now, Tom and I can be your points of contact if you have questions, and we'll do our best to answer your questions quickly or get consultation if we can't answer them independently.
In terms of the timeline, the overall timeline is unclear at this point because it's dependent on when they finalize the contract with the incentive manager and how long that contracting process takes. But we're looking to start training either pretty late this fall or right at the beginning of next year, and then launch as quickly thereafter as possible. I think sort of looking to that as a reasonable timeline estimate is probably the best ballpark that we can give you at this point. And as soon as we know what the timeline is and the incentive manager has been selected, then we'll do a wide scale communication to all of the participants to let you know kind of where things are moving.
So what questions do you have for us? Yeah. Oh, wait, hang on for the microphone.
Just in concept, is it useful to think about that? I can't remember the language, the care coordinator person, the coordinator,
Yep.
Being the person who runs the software in concept?
Yeah, so the CM coordinator will administer the urine drug testing, read the results to see if it's positive or negative, input those results into the incentive manager. So we'll do a lot of training in consultation with the incentive manager to teach the CM coordinator, backup CM coordinator, and CM supervisor how to use the manager.
Okay, and the supervisor, just concept wise, is that like a typical role, like a SUD counselor,
It's really someone who can oversee that particular service. So we're thinking it, again, it kind of depends on your particular agency and what the skills of your particular staff are. But we want someone who has some supervisorial authority that can say, you're doing this right or you're doing this wrong, as opposed to the CM coordinator and the backup coordinator really being kind of the frontline workers in that context. Also, we can't say how the incentive manager is going to work until we have it. But we're hoping it's going to be really, literally as much as opening whatever it is, putting in the results of the urine drug test, it spits out an amount and then tells you how it's going to be delivered. So we're hoping it's going to be very easy. Let's take one online. Christian, you're next.
Hey, thank you. Yeah, we had a few online, so I'll ask one of them for now. Can the question, sorry, I'm reading as they typed to me. This person was wondering if a program that doesn't do DMC-ODS billing could apply. This is from Santa Cruz Community Health Center. They bill through their primary care for outpatient addiction treatment, not DMC-ODS.
Yeah, at this point, because it's a Medicaid or in our state Medi-Cal funded service, you have to be eligible to provide that service. And the service is being funded through the drug Medi-Cal system. So in this initial launch, We're really only looking at DMC-ODS counties and sites. Now, our hope is that this is going to work and we're going to be able to expand and make this a service that's available more widely. But for this first go round, it does need to be people who fall within that context. You had a question. Can we get a mic right here? Oh, you have one over here.
So this is kind of follow up from the last question. For those of us who are in counties who aren't participating, what should we be looking out for?
It's a good question. I think that what we want to, on average, when a piece of research comes out that shows it's clinically significant and improves clinical services, it takes 17 years for that to be used in routine practice. 17 years of people dying in this particular case. So what we're trying to do is really, over the course of a year or two, demonstrate that this service works so that we can convince the Center for Medicaid Services, Medicaid and Medicare Services, and other funding agencies that it's not dangerous, that it's a good thing, that it can be implemented like buprenorphine in wide scale without creating additional problems along the way. And so hearing those rumors and listening to what the word is on the street as these services roll out is critical for all of us in order to hear what messaging is going on and help support what we know works. But where are the cracks and where are the problems in its implementation so that we can continue to refine it and do it the right way?
And
Thank you.
And it's one of the reasons, I mean, some of this may seem overly like controlling and structured and rigid. If we implement a single protocol in these 24 counties and we get good results, the feds can't say to us, oh, there was a variation of things happening in different counties, so you really didn't implement CM. We can say, well, everyone did this protocol, implements the protocol as it was written, and things were done consistently, and it'll broaden it up and make it available to everyone, is the hope, which is why we're being so careful around like following a single protocol.
With DHCS, we set out to implement an evidence-based practice, and what we did is implement an evidence-based practice. That's what we want. Yeah. Thanks, Courtney.
With selection of patients, so often what happens, you take care of one problem and another problem pops up. Mm-hmm. Would my opiate patients be excluded if once I get them on Sublocade, often they start using a lot of meth? So what I would like to do is take those patients and put them into this incentive to treat their meth.
I'll do it. Yes, that's a great question. So in order to be eligible to participate in the recovery incentives program, you have the participant has to go through the ASAM, ASAM assessment process, and they have to be diagnosed with a moderate to severe stimulant use disorder. And so, so if they have a co-occurring opioid use disorder and stimulant use disorder, they would be eligible for both services.
As long as their ASAM placement says they're appropriate for outpatient, intensive outpatient, or partial hospitalization, or opioid treatment. And so as long as their placement was appropriate to one of those sites, then they would qualify in this case, because we're only doing it in outpatient settings.
And the hope is that if folks are in residential treatment settings, that as they're nearing the completion of that phase of treatment, that part of the process to transition them to a less intense level of service will involve linking them with providers that are in the recovery incentives program, so that they could, if they meet the eligibility criteria, they can just go right into the recovery incentives program as they go from residential to outpatient.
So a positive test is not required for admission, as was done in many of the research studies, if you're familiar with it. They could move right from residential, where they haven't been using, into intensive outpatient and participate in the program, as long as they meet that diagnostic criteria and are deemed, and treatment is deemed to be medically necessary by your medical team. Christian, did we have another online question?
Yeah, we did. So one person mentioned that patients who were prescribed bupropion could get a false positive for amphetamine, and asked if this is being factored in, and whether there would be confirmatory urine testing to be sent instead of just relying on the point of
We are only going to rely on the point of care drug test. We are never sending out for laboratory confirmation for this particular service because the incentive has to be delivered immediately. Because of that, we're going to give you a template for a consent to work into your consent process within the context of your agency. And as part of that consent, there is a whole list of substances, both prescribed and otherwise, that could potentially result in a false positive. Some of them, if you're on treatment with an amphetamine for ADHD, for instance, it would not be appropriate to enter that person into the incentive manager program because they're always going to test positive. It just is not an appropriate service for them. But all of the other ones, we're going to ask them to consult with their physician as necessary, but to avoid using those substances because should they result in what would be a false positive in that case because of the cross reactivity, we still have to rely on the point of care urine drug testing, and they're not acknowledging that as they come into the treatment program. Great question. Mm-hmm.
So I just want to make sure that I understand correctly. So technically, amphetamine or methamphetamine does not have to be their primary drug of choice, correct?
That's right. Well, as long as the person is diagnosed with a moderate to severe stimulant use disorder, so they could also be using other substances.
As long as they meet the criteria to be
So it could be a secondary diagnosis, for
or a
instance.
tertiary. I think it's like primary, secondary, tertiary diagnosis.
Okay,
and
thank you.
It's not just amphetamine or methamphetamine, it also
cocaine.
includes cocaine.
Yeah. There's a question up front. Maybe we'll do one more question in the room and then we'll take one final question from the Zoom folks.
And Beth and I are around, and we are doing the overview training later. So we'll get into more details in that if you're particularly interested.
So if we have a lab on site at a substance use disorder facility or NTP or OTP, we would just provide you guys their threshold to meet the markers to be considered.
We need it to be a point of care urine drug test using an approved product. So if you have a urine drug test that meets all of the criteria for our particular product, we would need to have that approved by our toxicologist. So you'd submit it for approval by our toxicologist, and then it would be anyone in the whole system could use it. But it's not, you send the urine to your internal lab and they do the laboratory testing associated with that.
And
it's the point of care test that we're using.
They do both. They do point of care and confirmatory.
For our purposes, we're going to use the point of care test as the evaluation for this particular service.
Okay, great. Thank
you. So your point of care test may very well be one of the 4 that's been approved. If it's not, we'll make sure you know the process for submitting that for approval.
And if not, our recommendation would be that you consider one of those and switch during the time that you're offering in the incentive management program so that it's not creating additional complications for you. You're welcome.
All right, final question from
We
Kristen.
had just one more, and actually a couple of people asked this, so I guess it's a pretty good question. Is the CM program only for those patients that are in through Medi-Cal? What about those who don't qualify for Medi-Cal, either because they make more than allowable income, have other insurance, or are not eligible because they're not documented? They mentioned that this gets to be an equity concern.
The service is available for this particular pilot to clients who are Medi-Cal eligible and receiving services through Medi-Cal. We recognize that excludes a significant number of people from the process, including whole counties that are not DMC-ODS participants at this point, as well as individual clients within those counties that are participating. Because it's a Medi-Cal funded service and we're trying it for the first time, we're going to stick closely to those restrictions as we implement it this first time, with the hope that we'll be able to broaden it beyond that. It's going to be really fun. Beth and I are really nervous because it's a lot of responsibility to implement this kind of program with this size. And we're looking to all of you as partners to tell us what's working, but more importantly, to tell us what's not working, to tell us what the buzz is in the community, to tell us what the concerns are so that we can all work together to resolve those, because this is a service that works. This is a service that will stop people from dying. Let's work together to make sure it happens, okay? Thank you all very much.
Thank you, everyone.